Dear doctors, today in this video I am going to discuss questions, their answers and explanation related to EDIC Part 1. I will be focusing on questions related to mechanical ventilation, so let's move on.
Question 1. A patient on volume-controlled ventilation develops a sudden rise in peak airway pressure but plateau pressure remains unchanged. What is most likely cause? Pneumothorax. B. Endobronchial intubation. C. Kinking of endotracheal tube. D. Pulmonary edema. E. Increasing autopeep. Correct answer is C. Kinking of endotracheal tube. Explanation. If peak pressure rises but plateau pressure is unchanged, this indicates increased airway resistance. For example, bronchospasm or endotracheal obstruction like kinking or mucus plugging. In contrast, if both peak and plateau pressure rise, it reflects decreased compliance. Question 2. During pressure-controlled ventilation, which factor determines tidal volume delivered? Inspiratory flow rate. B. Set pressure and lung compliance. C. Respiratory rate. D. Inspiratory to expiratory time ratio. Set tidal volume. Correct answer is B. Set inspiratory pressure and lung compliance. Explanation. In pressure-controlled ventilation, tidal volume depends on the driving pressure. Means set inspiratory pressure minus PEEP. And the lung-chest compliance. Question 3. A patient with severe asthma on mechanical ventilation shows evidence of autopeep. The best immediate step is decrease respiratory rate. B. Decrease expiratory time. C. Decrease tidal volume. D. Disconnect ventilator. E. Increase PEEP. Correct answer is A. Decrease respiratory rate. Explanation. Autopeep arises from incomplete exhalation. Increase expiratory time by reducing respiratory rate or increasing inspiratory flow to allow full exhalation. While decreasing tidal volume also lengthens exhalation, lowering the respiratory rate is more effective way to create the necessary long expiratory phase needed to de-air trap the lung and minimize autopeep. Disconnecting the ventilator is an option in extreme life-threatening situation. Question 4. Which of the following is an absolute contraindication to non-invasive ventilation? COPD exacerbation with pH 7.20. B. Cardiogenic pulmonary edema. C. Postoperative atelectasis. D. Reduced consciousness with poor airway protection. E. Obesity hypoventilation syndrome. Correct answer is D. Reduced consciousness with poor airway protection. Explanation. Non-invasive ventilation requires intact airway reflexes. Depressed consciousness increases aspiration risk, making ventilation unsafe. Question 5. A patient with partial pressure of arterial oxygen 90 mm of mercury on oxygen 80% after 24 hours of ARDS treatment. What is the best next step? Continue oxygen 80%. B. Increase oxygen to 100%. C. Reduce oxygen gradually while monitoring oxygenation. D. Reduce PEEP. E. Increase tidal volume. Correct answer is C. Reduce oxygen gradually while monitoring oxygenation. Explanation. High oxygen means more than 60% increases oxygen toxicity risk. So oxygen should be reduced gradually, while maintaining partial pressure of oxygen 60 or more and saturation 90% or more. Question 6. Which parameter determines oxygenation during mechanical ventilation? Respiratory rate. B. Tidal volume. C. Mean airway pressure. D. Inspiratory flow. E. Minute ventilation. Correct answer is C. Mean airway pressure. Explanation. Oxygenation depends on delivered oxygen concentration and mean airway pressure. Mean airway pressure is the average pressure in the patient's airway during a full respiratory cycle. It improves oxygenation by increasing the functional residual capacity, recruiting collapsed alveoli, and ensuring better ventilation perfusion matching. Mean airway pressure is primarily influenced by PEEP any inspiratory time or I/E ratio. PEEP is the most important determinant of mean airway pressure, especially in conditions like ARDS. Question 7. A 35-year-old man with severe head injury, GCS6, is being ventilated. Which statement is most appropriate? Maintain partial pressure of carbon dioxide between 25 to 30 millimeters of mercury to reduce intracranial pressure chronically. B. Avoid PEEP completely to prevent ICP rise. C. Maintain normocapnia and avoid hyperoxia. D. Target high tidal volume for CO2 clearance. E. Allow permissive hypercapnia. Correct answer is C. Maintain normocapnia and avoid hyperoxia. Explanation. Hypercapnia causes cerebral vasodilation leading to rise in intracranial pressure. Hypocapnia causes vasoconstriction leading to cerebral ischemia. So, maintain normocapnia and adequate oxygenation. Avoid hyperoxia.
Dear doctors, here I finish. See you in my next video with more questions on adding part 1. Till then, bye and take care.